I'd just like to say, first of all, a really heartfelt thank you to the organisers for inviting me to speak today. Mario and Julie have done a fantastic job organising this conference and making us all feel very welcome and organised, as we expect from the Swiss. So this first slide I actually changed yesterday morning. I thought it was a nice evolution of my clinical practice, where I started off early days in Adelaide, where basically there's only one sport, and that's Australian rules football. And that was where I first developed interest in groin problems. And there was a lot of history of management of groin problems in Adelaide at the time. And then when I moved to the Institute of Sport, where I worked for about 20 years, I worked with the Australian women's water polo team. And we also saw a lot of groin problems in that sport. And then eventually, as everyone does, I moved to football, and particularly when I moved over to Doha, where I conducted my PhD research. So, as Christian mentioned, there's three different types of injury prevention. We have primary, secondary, and tertiary injury prevention. And when we're looking at primary prevention, we're looking at addressing causal factors or risk factors. And the idea is that we screen at the beginning of the season, we look at factors like strength, range of motion, movement quality, and then we provide individualised exercise programs to the athletes that we consider at risk. And I can tell you I have spent a lot of my career screening and providing individualised exercise programs. And I always wondered whether they were really going to be effective, and could I actually prevent injuries by spending all this time. The other form of primary prevention is looking at group exercise programs, so things like the FIFA 11 Plus and some of the stuff that's been discussed today. And secondary prevention. Now, secondary prevention is where we do early detection of existing problems. And that's basically what Christian was talking about with Martin Wallen's work. But then we have to follow that up with an appropriate intervention. And that intervention may be strengthening of the adductors, it may be looking at range of motion, it may be looking at load management, whatever is appropriate to the condition. And tertiary prevention is about reducing complications and the long-term burden of injury. So it's really looking at effective groin injury rehab to try to prevent recurrence, but also looking at maintaining general fitness and reducing the effect of potentially deloading with risk factors for other injuries. So it's about preparing them to return to play as well. So what's the current state of evidence for groin injury prevention? Well, you can't have an injury prevention talk without showing the von Mechelen model. So here is the von Mechelen model, which we're all so familiar with. So starting off with establishing the extent of the problem. Where are we with groin injury prevention? Well, as Christian mentioned, a lot of the epidemiology and the research looking at groin injuries, and particularly looking at prevention, has been done in football. So we know that there is a really high prevalence of groin problems in football players, particularly in male football players, and that about 1 in 5 professional male football players will have a time-loss groin injury per season. And as Christian mentioned, there is a much higher prevalence when you're looking at groin pain. That's not time loss. It is the third most common injury, so there is a high frequency, and there's certainly a high burden and also a troublesome recurrence rate. Around 70% of groin problems will be of gradual onset, and around 2 out of 3 of them will be adductor-related groin pain. What about groin pain in sports other than football? We don't all work in football. So in ice hockey, there's quite a lot of literature and quite a lot of research that's been done showing that groin pain is a problem in ice hockey, but also in a lot of the other football codes. So these pivoting, multi-directional sports like Australian rules football, rugby, Gaelic football, there is also a lot of problems with the groin. But even sports like lacrosse and even cricket and basketball, we've seen some studies published in groin pain. What we know is that across sports, if you have the same level of males and females playing that sport, there is a higher risk of males developing groin injuries than females. We also know that the time loss definition desperately underestimates the injury burden of groin pain, and it certainly is a complex and multifactorial etiology and has been described by Mario Bazzini as the Bermuda Triangle of sports medicine. So we actually know quite a lot about the severity of the problem. Yep, it is a problem, has a high prevalence, and has a high burden in sport. So what about the etiology and mechanism of injury for groin problems? Well, we need to look at risk factors, both intrinsic and extrinsic risk factors. But we also need to look at the injury mechanisms, and we do that by analysing known injuries. So the focus of my PhD research was looking at the intrinsic risk factors for groin pain. What do we know about the intrinsic risk factors? What's been done before? Well, there's been actually quite a number of studies that have looked at the intrinsic risk factors for groin pain in athletes. And these have been synthesised in a few recent systematic reviews, and consistently previous groin injury comes up as the most consistent risk factor for groin injuries, but also reduction in adduction strength, and that's both absolute and relative to abduction strength, which is the ratio that was mentioned before. There is some conflicting evidence about range of motion. So the Ryan study and the TAC study found some evidence that there is a loss of range of motion is a risk factor, whereas the Whitaker systematic review found level 2 evidence that range of motion is not related or does not associate with groin injury risk. But I was wondering, perhaps we've been missing an intrinsic risk factor. What about this little bump on the femur that we heard from Rinche this morning? Is that potentially an intrinsic risk factor that we haven't looked at yet? So that was one of the aims of our intrinsic risk factor study. We wanted to find what risk factors we could identify for hip and groin injury to see if we could determine that at-risk individual by screening. But we also wanted to look at the association between bony hip morphology, so the shape of the hip bones, and groin injury risk. And I was able to conduct this study in Doha, in Qatar, and it was really a fantastic place to be able to do this study. And that's because when you fly into Hamad International Airport, you drive for about 20-30 minutes, depending on the traffic, and you arrive at Aspetar Sports Medicine Hospital. And all of these football clubs, these professional football clubs in Qatar, you can actually get around to them almost in one day. And they all come into Aspetar for their annual screening. And they have to be signed off on their annual screening before they're allowed to play, in theory. So we have this centralised database of screening results, and there also has been injury surveillance which has been set up many years ago by one of my colleagues, Cristiano Arali. So our screening battery included some demographic information. We conducted some musculoskeletal screening tests, and we also were able to do X-ray screening all at Aspetar. The screening included 2 pain provocation tests more specific to the hip and 2 more specific for adductor-related groin pain. In terms of range of motion, we looked at internal and external rotation at 90 degrees and internal rotation also in prone. We did hip abduction in side lying and the bent knee fallout test. For strength, we chose the eccentric adduction and abduction in side lying, and we also quantified the adductor squeeze at 45 degrees of hip flexion using a dynamometer. In terms of X-ray screening, we did an AP in 15 degrees of internal rotation and the 45-degree done view to visualise the femoral head-neck junction. In terms of bony morphology, we defined a cam as an alpha angle greater than 60 degrees and a large cam as an alpha angle greater than 78 degrees. Pincer was a lateral centre edge angle greater than 40 degrees, and acetabular dysplasia was a lateral centre edge angle less than 20 degrees. So we actually screened 575 players for these 2 seasons of the Qatar Stars League. And out of those, we were able to include 438 players in the prospective risk factor study. And around about half of these players were screened in both seasons, so that's why we have the 609 player seasons. And we conducted injury and exposure surveillance across the league, and this was according to the Consensus on Injury Definitions, which was published by Fuller. And all of our injuries were categorised post hoc using the categorisation of the Doha Agreement. So what did we find? We were really lucky because we were able to have 113 hip and groin injuries, which is a nice big data set for a dependent variable. 75% of these were adductor-related groin pain, so it just fits the pattern that we've been talking about all day. Interestingly, we only had one injury which was classified as a hip-related groin pain. And what was the prevalence of CAM? It was actually more common to have a CAM than not have a CAM. And large CAM, around about a third of our players had a large CAM in one or both hips. Pincer prevalence was relatively rare with our definition, and acetabular dysplasia was also not that common. So we put all our variables into a multivariate Cox regression analysis, and this is the results. When we had all hip and groin injuries as a dependent variable, so this is all the categorisations according to the Doha Agreement, we found previous hip and groin injury was a risk factor for future injury, no surprise there. But interestingly, we found higher than normal eccentric adduction strength was a risk factor. And because we had so many categorised as adductor-related groin pain, we then did a secondary analysis looking at that as a dependent variable, and we found again that previous hip and groin injury was a risk factor for future injury of adductor. But here we had lower than normal eccentric adduction strength was a risk factor, which is what we were kind of expecting. But let's have a look at this. So here we have box plots of the means between the injured and uninjured group. On the left-hand side, you can see all hip and groin injuries, and on the right-hand side, adductor-related groin injuries. Those means don't look very different, do they? And in fact, it actually equates to 8 newtons. And the error of measurement for this measure is 30 newtons. So certainly this measure is not sensitive enough to predict the athlete that's going to get injured. So we can say that yes, adduction strength is associated and is a risk factor, but it's a relatively weak risk factor. And certainly we can't use this test to try to predict which one of these players is going to have an adductor-related groin pain. So what about previous hip and groin injury? Well, if we look at our football team here, we know that 2 of our players have had an injury last season. So perhaps we want to do some extra prevention measures with those 2 players. But we found that 8% of the players that didn't have an injury last season also got a groin injury this season. So if we only intervene with the 2 guys that had the injury last season, we're going to miss this guy's injury that we potentially could have prevented. So what does that mean? It means that aren't we better just implementing our injury prevention measures to the whole team rather than just the individuals with the past history? So again, that's a primary prevention measure. So it looks like doing this screening to try to predict those that will get injured and doing the individualised exercise programs is perhaps not time and money well spent. And maybe we should just be looking at things like the Copenhagen adduction exercise as a primary prevention measure. And what about the bony hip morphology? Well, have a look at this forest plot. You can see the confidence intervals all across the one, which means no association. So we found no association between bony hip morphology and groin injury risk in our professional male football players in Qatar. Bony morphology is not a risk factor for groin injury. Interesting. Okay, so let's go on to extrinsic risk factors. Again, this has been looked at in the literature, but not quite as extensively as intrinsic risk factors. It has been synthesised in these systematic reviews, and it seems like a lower level of sport-specific training prior to the season and also a higher level of play are risk factors for groin injuries within that season. So with the help of my Data Dave, the amazing data analytics expert, we have been looking at the same data set to examine the relationship between workload and time lost groin injury. And we wanted to determine if previously identified intrinsic risk factors, so that was the previous injury and eccentric adduction strength, perhaps were effect modifiers to this relationship. So I'll just orientate you to this plot, and this is just preliminary results, so please don't tweet any of this. You can see here, is this working? Yeah. So, I don't think you can see it, but so the hazard ratio is on the right-hand side. And you can see here where the aqua colour is, that's where the highest risk is. And where the deeper purple, that's where they're relatively protected for groin injury risk. So what we've decided to look at here is the interaction between acute and chronic workload, rather than looking purely at the acute or chronic chronic workload ratio. And this is a three-dimensional plot. So you could actually take any spot in this plot and then look at the relationship between acute workload, chronic workload, and calculate the hazard ratio. Of course, the confidence intervals aren't built into this plot, so just bear that in mind. But if we look at where the ratio or the risk looks to be the highest, it's actually at the point where there's a high chronic load and a high acute load, which is kind of what Mick was talking about this morning, where you have an athlete that's just basically overloaded and they can cope. This week I can't cope. So there does seem to be some relationship between workload and groin injury risk, which for those of us that have been working clinically with groin injuries are not surprised at. So we're still exploring the optimal analysis methods, and I'm a little bit scared of Franco here, so I'm just going to walk away so I can't see him. But we're looking at the coupled versus the uncoupled. We're looking at the acute or chronic workload ratio as a continuous variable, and we're still exploring like the rest of the world, what's the optimal analysis methods to use. But it does look like there's a very complex but non-linear relationship between workload and groin injury risk. And we need to explore this risk further. So what about injury mechanisms? Again, we need to look at analysis of known injuries. And Andreas has published earlier this year, we looked at 17 acute adductor longus injuries on video. Hopefully it works. Yes, so this is one of the injuries. And this is a really, really interesting case. So this guy actually came in and saw me for screening. And he looked horrible. He had really quite nasty pain on the Copenhagen adduction test. His eccentric adduction strength was down, and we had a long discussion with the doctor asking, please, please, please keep this guy out from playing. Anyway, he went and played and he ruptured his adductor longus. So the interesting thing about this this video is when you look at actually what he did, it's a fairly innocuous action, isn't it? I mean, it doesn't look like a huge amount of load there. And he's had a complete rupture of his adductor longus. And this is what we found with a lot of the injuries, that it doesn't seem to, it's just a small change of direction, a little bit of a kick, jumping. It was really, did not require a huge amount of force to create the groin injuries. We found that 71% were in non-contact situations and 53% were after a quick reaction to play. Change of direction activity like that one resulted in 35% of the injuries. Kicking was another sort of third, 29% of the injuries, and jumping was 12%, and the rest we couldn't really categorise. And this is where the groin injuries occurred across the field, so no real pattern there. So this is looking at acute adductor longus injury mechanisms. However, we know that 70% of groin injuries approximately are due to overuse. So we really need to explore more about load and its relationship with injury mechanisms for groin injuries. So as I mentioned before, we have a pretty good idea of the epi. We're starting to understand the risk factors and the injury mechanisms for groin injuries. But there is a school of thought that thinks, let's just forget about doing these risk factor studies and let's just get in there and do RCTs of injury prevention measures and see what works. And that's a very practical approach. So one of Christian's PhD students, Ernest, did a systematic review a few years ago now, and he synthesised the literature of some of the injury prevention programs that have been done for groin injuries in football. And as you can see here, with the pooled result, we really haven't been particularly successful. Why is that? There may be lots of reasons why there could be poor success. It might be because we in the past have not had good consistency of terminology and diagnosis. So we didn't even really have a clear picture of what injuries we were trying to prevent. But also this time loss definition is a really big problem, and I'm pretty confident, Per, that if you'd done the overuse questionnaire in your study, you would have shown a pretty significant reduction. And as and Christian described this study, so I won't go into detail about it, but we have this new study that was published this year with 34 Norwegian football teams that looked at the Copenhagen adduction exercise and looked at prevalence of groin pain, not just time loss, and found a 41% reduction in the intervention group. So maybe primary prevention is possible for groin injuries. There may be other reasons. Perhaps we haven't considered the relationship between the intrinsic and extrinsic risk factors well enough. And I think this is what Martin's really done well, is he's looked at an alert system for when adduction strength and Haigos scores are looking like they're getting into trouble, and then implementing a multimodal management plan on the spot. And as Christian mentioned, if you're working to get closely with a team like that and in the team environment, it's quite easy to implement this kind of prevention measure. And it's basically a secondary prevention measure. So your appropriate intervention may be modification of load. It might not be pulling them out of training, but perhaps just reducing the number of long kicks they do in that training. It might be something as simple as that. And what about tertiary prevention? As I mentioned, it's really just looking at effective rehab and minimising that long-term burden of injury, because these guys are out for a long time sometimes. And we have, lots of evidence now that exercise-based rehabilitation for long-standing adductor-related groin pain is effective. And we're really looking at impairments that are determined in our assessment. We use outcome measures such as the Haigos or the alert system or the Copenhagen adduction pain provocation test, and these determine the progression of your load in your exercise program. And the development and the return to play process is guided by these outcome measures. So we're probably a long way away from this complex systems approach in identifying everything for groin injuries, but we are getting closer. We have a good knowledge of epidemiology. We're starting to understand the risk factors and injury mechanisms for groin injuries. We have some effective risk reduction strategies that have been implemented and shown to be effective. So in terms of our primary prevention, we're looking at things doing group exercise programs such as the Copenhagen adduction exercise, and if I was a coach of a team, I would definitely have that exercise in their warm-up. Probably not a good idea to do screening as a primary prevention measure, but good to do screening as a secondary prevention measure to detect those early signs of someone getting into trouble. And using these sensitive pain provocation tests and perhaps the Haigos to identify and implement before the player starts getting into trouble. And then Andreas is going to talk a lot more about criterion-based rehab and how to do that effectively for tertiary prevention. So I think the future is bright for groin injury prevention. I think we've come a long way from when I started my PhD 6 years ago, and I would just like to thank all of my fantastic co-authors for my PhD. Thank you.